Hello everyone, my name is Xanthaki and I'm a psychologist. Today I'm going to talk about therapeutic interventions for the positive psychotic symptoms and specifically about cognitive behavioral therapy for delusions, voices and paranoia. As you know, schizophrenia is characterized by positive symptoms such as hallucinations, delusions, and thought disorder, and negative symptoms such as social withdrawal, poverty of speech, and lack of motivation. In regard to hallucinations, auditory hallucinations, and particularly voices, are the most common, especially in Western societies. There are remarkable individual differences in the type of delusions and in the type of auditory hallucinations people experience. As Bentel had suggested, schizophrenia is a disease with no particular symptoms, no particular course, no particular outcome, and which responds to no particular treatment. There is about 1% of the population that are affected by schizophrenia, while 10 to 15% of the population have heard voices or experienced hallucinations at some point in their life, but have not come into contact with professionals. And that's the reason for that is because people, whether they will come in contact with professionals or not, depends on how well they can cope with their experiences. In this presentation, the focus will be on how cognitive behavioral therapy can be effective in lessening the severity and impact of persistent hallucinations and delusions, and in maximizing the patient's ability to cope with their symptoms. For most people with schizophrenia, antipsychotic medication can offer very much relief from their symptoms, but a range of cognitive behavioral strategies may offer a very useful adjunct to medication in helping people to manage their experiences better. So the main concept of CBT is that psychological difficulties depend on how people think or interpret events, that is their cognitions, how they respond to these events, that's their behavior, and how that makes them feel, their emotions. So CBT seeks to achieve the desired changes by modifying the underlying thoughts and beliefs. It's a structured approach and has three main goals: to reduce the distress and disability associated with their symptoms, to increase their capacity to cope with their experience, and to promote their active participation in preventing relapse. So overall, it mainly aims to improve functioning and reduce distress rather than to completely remove or cure any symptoms. Generally, it's recommended that CBT is given to the patient when they're at their least psychotic, both because rapport is likely to be easier to retain and also because less firmly held delusions are easier to challenge. So in the first stage is obviously to build a collaborative and non-judgmental and therapeutic, empathic therapeutic relationship where the patient feels understood. So good rapport and trust are essential in all types of relationship, but especially with psychotic people is really important, as they can be quite often suspicious, angry at mental health services, or deny the relevance of therapy for the problems. Gradually, the therapist moves to a more structured assessment interviewing and aims to arrive at a preliminary set of goals that are realistic and which provide hope for the future, such as to facilitate the patient to go out and feel less paranoid when out of home. The second stage involves the therapist offering a new perspective about the nature of their experiences, which is based on a formulation of psychotic symptoms and vulnerability. The formulation is a statement of what the person sees as a problem, how this may come about, and what is keeping them going. The third stage typically involves the therapist promoting insight work and providing training in the use of various cognitive behavioral strategies to help the patients cope with distressing psychotic experiences. So an important step in this part is that of normalization, that is, the attribution of delusions and hallucinations to events such as biochemical disturbances, extreme stress, and sleep deprivation. And this process of normalization aims to decatastrophize their experience and to make psychotic experiences seem less frightening. Psychoeducation about psychosis and the symptom of schizophrenia can act effectively in reducing patients' distress associated with their symptoms. Usually, CBT can be applied more quickly to auditory hallucinations than to delusions because the phenomenon of the voices can be more easily agreed and discussed. In regard to hallucination, the main approach is to accept that the experience of the hallucination is real, but then to work with the patient to modify the interpretation of that experience. Since judging voices and delusions as threatening can be very disturbing and frightening, the primary aim of CBT is to disempower them. Typically, the therapist works with the content of the hallucination and the belief about its origin. During the assessment, the therapist can examine whether the patient has found or noticed anything that affects the voices that makes them better or worse. And according to Chadwick, exercises that challenge beliefs about the uncontrollability of the voices can have a significant effect in how powerful and distressing they are considered by the individual. The most usual end goal of insight promotion is for the person to understand that the voice comes from within them, as they mistake their inner speech as other people's speech. The most commonly reported strategies discovered by people to help control their voices involve some sort of distraction that engages their attention, and in particular, activities that involve the use of language. This is because the language areas of the brain are involved in auditory hallucinations, and thus using these areas for some other language activity prevents them from being used to produce hallucinations. The more attention is demanded from the person to do the activity, the more effective the activity will be as a distraction, but this has to be balanced with the problem of engaging the patient in a demanding task. In the case of auditory hallucinations, it's usually a good strategy to start by using a Walkman or some music so that it can help them stop the voices or reduce them. This is quite effective and a popular way of controlling the voices. It can provide the patient with immediate relief from the voices, but also the realization that they have a certain amount of control over them. Subvocal speech can also be very beneficial by preventing the vocal cord movements that accompany at least some auditory hallucinations. Other strategies include repeating sequences of number and subvocal singing, which may be less attention demanding. Additionally, commonly used techniques include either increasing or decreasing social contact, depending on whether it makes the symptom worse or better, setting aside a set period in each day when they listen to the voices and ignore them at other times, and relaxation or breathing exercises, since hallucinations are more likely to occur when the patient is aroused. So while on the one hand, techniques that distract attention have been found to be quite useful, on the other hand, techniques that focuses on the voices can also be beneficial. This can be done by recording details about the voices and focusing on its physical characteristics. This can help people to distance themselves from the voices and the power they have over them. Often patients have difficulty distinguishing such characteristics, and this can act as evidence that it's different from the voices of other people and that they do not come from a physical source. It's also a good technique to ask whether others can hear it, because most report that others do not hear the voice, which is inconsistent with the view that it comes from a real person. Additionally, carefully challenging the evidence for the validity of the hallucinations, for example, by showing to them that sometimes they tell lies, can be very effective in reducing its authority and importance. In general, CBT therapists try to encourage the person not to believe their voices and to decrease feelings of personal responsibility for voice content. Therapy may only rarely actually stop the voices, but it can have clinically significant changes in the way a person reacts to the voice. Haddock suggested that a combination of both distraction and focusing techniques can be the most effective treatment strategy for most of the patients. In the fourth stage, therapy proceeds towards a focus on specific delusional beliefs and paranoid misinterpretations, ensuring first that a good trusting relationship has been established, and then attempting belief modification. Patients usually make cognitive biases, such as concentrating on evidence confirming their delusions while passing over evidence that contradicts them, and they may jump to conclusions on the basis of inadequate evidence. Another error of thinking that occurs most frequently in schizophrenia is that of personalization or self-reference. Often several CBT strategies are used in combination, and they all involve gentle discussions about the evidence for the belief, rather than directly confronting and challenging the belief. Any direct question that implies doubt about the person's delusions is likely to lead to loss of rapport and to adversely affect the therapeutic alliance. The therapist attempts to modify the patient's interpretation by using logical reasoning and looking for alternative explanations. they can guide the patient's thinking by asking appropriate questions, Socratic questioning, and reality testing is used to question the evidence for the assumptions on which delusional beliefs are based. The fifth stage in therapy targets the person's dysfunctional assumptions about themselves, such as of being worthless, unwanted, or dangerous, and about others, that they may harbor negative attitudes toward the person. In psychotic patients, we often come across the poor me paranoid delusions, where people tend to believe that they are innocent victims of conspiracies, and the bad me delusions, where they tend to believe that others have a good reason to harm them. Work involves advice on how to use CBT strategies for psychotic symptoms, strategies to manage social disability, identify prodromal sign of relapse, and develop an individualized plan to manage future occurrences of the symptom. The essence is for the person to be able to identify the symptoms when they occur so that they can put into effect measures to counter them. Where medication has proved beneficial, a key aspect of CBT may to improve their compliance. So although the evaluation of CBT for psychosis is in its early stages, evidence is accumulating for its efficacy and cost effectiveness. There is convincing evidence from controlled trials for the effectiveness of CBT at reducing symptoms, particularly symptoms of delusions and hallucinations and the distress associated with that. However, one should take into consideration that these kind of techniques might face significant obstacles when applied to psychotic patients, because diaries and homework assignments can be quite difficult for the patient to follow and to look for the links between thoughts, feelings, physiology, and behavior. And they might be quite difficult to work with because they cannot sometimes work at an abstract level of thinking. Communication difficulties also exist in many cases of severe thought disorder. And even though the highly structured approach of CBT can help, it's necessary that the therapists are all creative and flexible. For example, they can do strategies like not holding rigid agendas, having shorter sessions, simplifying statements, and of course continuously checking for the patient's understanding. Finally, it's worth mentioning that usually CBT is offered to people who have some distressing experiences, but who are able to attend outpatient appointments. And it's less often provided to those who are inpatients in a hospital, even though they can also benefit from psychological interventions. So it's crucial to identify which aspect of CBT intervention are most relevant for the care of individuals in hospital settings, and to evaluate their effectiveness in these settings. Providing psychological interventions together with medication can be very effective for the patients who will receive a more holistic approach to their care that matches better the various needs. If you have any questions.